All right, everyone, it looks like it is 12 o'clock, so we'll go ahead and get started. Welcome to this month's Northwest ATTC webinar. I'm Meg Bruner, and I am your host for today, sitting in for Jen Verbeck. We're excited to have Dr. Deborah Hasin presenting for us today on time trends in cannabis use disorder, and psychiatric comorbidity, individual and state level influences. Next slide, please, Dr. Hasin.
Let me get the slideshow going.
Great, thank you.
Can you see the slideshow without the little chat thing?
I can see the slides great.
Okay, great.
All right, a couple of quick housekeeping things for everybody. First, if you have any questions for our presenter, can you go back one? Dr. Hasin, can you go back one?
Yeah, I'm going to try. I have my screen partly obscured with the chat thing, so I'm going to just try to get rid of it here.
Okay.
There we go. Okay, good.
Can you go back to the chat slide? There we go. That's it. Thank you. Oh.
Here we go.
All right, great. Thank you. So if you have any questions for our presenter, please type them in the chat box at any time, and we'll answer them at the end of the presentation. Make sure that the little drop box next to 2 is set to everyone if you want everyone to be able to see your message, or if you want to target it to someone, you can change that setting there. Next slide. You'll also be getting an email later this afternoon that has a link to a survey in it. Please take that survey. It helps us make sure we're bringing you the content you're interested in and helps us continue to offer free and low-cost events. That email will also have a link to download the slides from today and a link to our website where you'll be able to find a recording of the webinar tomorrow. Next slide. All right, additionally, we'll be sending everyone who attends this live webinar a certificate of attendance in about a week. You don't need to do anything to get the certificate unless you're watching this in a group. In that case, please have someone in your group email us within 1 business day with the names and email addresses for everyone who wants a certificate. Our email is on the slide there, and it's northwest@attcnetwork.org. Next slide. Oh, might have gone the wrong way there. There we go. All right. All right. Now on to the webinar. I would like to take a moment to acknowledge our partners at the Addictions, Drug, and Alcohol Institute's Cannabis Education and Research Program, Dr. Bia Carlini and Sharon Garrett, who helped arrange this month's topic with Dr. Hasin. Thank you both for collaborating on this webinar with us. And I am pleased to introduce our speaker today, Dr. Deborah Hasin, who is a professor of epidemiology at Columbia University. She directs the NIDA Substance Abuse Training Program in the Department of Epidemiology and also directs the Substance Dependent Research Group at New York State Psychiatric Institute. Dr. Hasin conducts research on drug and alcohol use and substance use disorders in the general population and in specialized vulnerable groups. She has published over 500 papers, wow, and her studies are funded by NIDA, NIAAA, and other organizations. And with that, I will turn it over to you, Dr. Hasin. Thank you so much for being here.
Well, great. Thank you so much for inviting me to do this. I look forward to hearing what people have to say and what their questions are at the end. I'll try to make sure to leave some time for that. Okay, so this is where I am in New York City, where I work. That's the George Washington Bridge that you see there, and you have a view of the Columbia University Medical Center here. Pretty different environment from where you guys are, but a lot of the issues are the same with some differences. So here's what I'm going to be talking about today. I'm going to get through all of these different topics, I believe. So I'm going to start out by talking about some potential benefits and potential harms of adult cannabis use. I'll be talking about the definitions of cannabis use disorder. I'll be talking about what people call the changing cannabis landscape, which is potential environmental influences on the prevalence of adult cannabis use and cannabis use disorder. I'll be talking about time trends and the prevalence of adult cannabis use disorder, which reflect, I think, to a large extent, some of the changes in the landscape. And I'll be talking about state medical and recreational cannabis laws and their relationship to adult cannabis use disorder, and then talk at the last topic, cannabis use disorder trends by comorbidity. And in particular, I'll be talking about differences between patients with chronic pain and without chronic pain, and then also between those with psychiatric disorders and those with no psychiatric disorders. So with that, I'll start out by talking about some potential individual benefits and societal benefits as well. So certainly one can't really start a talk about cannabis at this point without talking about some of the individual or personal benefits. So first of all is enjoyment. Just as many people enjoy an alcoholic drink without harm, many people also enjoy using cannabis. People use cannabis to treat medical conditions, for example, pain or nausea, epilepsy, many different conditions. And then, from the standpoint of civil liberties in the states that have legalized cannabis use, this gives people a freedom from fear of arrest. And then in terms of societal benefits, certainly legalization at this point achieves social justice aims, and really undercuts what had been very pronounced racial disparities in arrest rates for simple marijuana possession. Once legalization occurs, that level of disparity, it doesn't go away completely, but it's reduced a lot. And societal benefits also include business and job growth. I'll be talking some about commercialization, and then also states and local governments are enthusiastic about legalization because it generates revenue for them. So what about one of the potential benefits, cannabis as a treatment for medical conditions? Well, people have examined this actually quite a lot. There have been a lot of randomized clinical trials of cannabis as a treatment for pain and other conditions, and many, many observational studies as well. So I have several figures that are in this form. So I thought what would be useful to do is to just make sure that everybody that's viewing this can understand this type of a figure. This is called a forest plot. And what you see, you have a line that goes down the middle. And then on the one side of the line are studies that are beneficial in terms of their results. And on the other side are studies that are harmful. So here is a study that showed a beneficial result of cannabis use. And these are the error bars or the confidence intervals. They also indicate whether the findings were significant or not. In this case, the study is significant because the confidence intervals don't touch this middle line that indicates no difference between the treated and untreated participants, or the treated and placebo-treated participants. So in this particular slide, we see to the left are the beneficial outcomes, and to the right are the harmful outcomes. So these on the top are patients with chronic pain, and we see in this particular review, it looks like the studies were in favor of reduction of chronic pain because all three, if I have a little arrow here, so all three of the point estimates were in the beneficial side, and the confidence intervals don't touch this line, indicating no difference between the treatment groups. But if you look at the multiple sclerosis group, here you see that in general, the results were actually, the patients that were treated did worse. These were the outcomes were harmful. The same thing, and for inflammatory bowel disease, there was an outcome that was beneficial. And then for cancer symptoms, the influence was pretty mixed. So looking a little bit more closely at pain, which is almost universally a condition that medical cannabis laws have been prescribed for, this is another forest plot. And so we see the same idea here. We have a line that goes down the middle. That indicates that there was no difference between the treated groups and the placebo groups. And here we start to see that there's some mixed results. So on top, we have treatments for acute pain where the point estimates are to the right, suggesting the cannabis is better, but the confidence intervals cross this line, indicating no difference between the treated and control groups. And so that says that the studies were not conclusive because they weren't significant. A mixed result also for cancer pain. Neuropathic pain, it looks like the results were uniformly better because the error bars none of them touch this middle line. But this other one, neuropathic pain lasting at least 4 weeks, We have a mixed result, multiple sclerosis pain, non-significant differences for pain for, oops. Here, the bottom line with this slide is that there's a pretty mixed picture in terms of the results of these studies, which is a little bit different from the widespread, commonly held belief that cannabis is a very useful treatment for all kinds of pain and actually for all kinds of other medical conditions as well. Here's another review that was published recently that's consistent with what we've seen so far. The authors aggregated a number of studies with, once the number of studies was increased, there were a fair number of patients. And a lot of these studies really didn't show, when you put them all together, strong results favoring the efficacy of cannabis for pain reduction. So then the question is, why are these study results so different from people's beliefs in the general population? So a paper came out just recently where the authors reviewed 56 randomized clinical trials for pain. They also reviewed treatment of cannabis, of post-traumatic stress disorder for cannabis, but I'm going to focus here on the results for pain. So what these authors found was that there were unusually high positive responses in the placebo groups. And this response suggested that reported improvements in pain may be attributable to a placebo effect or favorable expectancies of the cannabinoid effects rather than a biological effect of the treatment itself. And this becomes an issue if cannabis has adverse secondary consequences. So I'm going to now shift and talk a little bit about some potential harms related to cannabis. First things first, when talking about harms of cannabis, we are not talking about the same mortality profile as we're talking about when we speak about opioids. So, the opioid overdose crisis has really sapped some of the longevity estimates of the US general population. It's a leading cause of death in US adults. Cannabis does not have that kind of morbidity and mortality profile, but at the same time, cannabis is not a harmless substance, as has been shown in quite a number of different studies. So here's another forest plot. This is another meta-analysis. And this slide shows results from studies in 3 different groups. The top group is studies that were conducted in pregnant women. And you see in a middle column there, the outcome. These were the outcomes that were measured in the studies. Here, the middle line, once again, shows no difference between treatment and control groups. But here on the right is the harmful outcomes. And you can see that the treated group, those with cannabis, actually did worse than the control group, because here you have point estimates that are all on the harmful side of this figure, and none of the confidence intervals touch that middle vertical bar. The next group that was examined in this paper was drivers. And once again, we see that there's harmful or adverse outcomes of cannabis amongst car drivers in terms of car crashes and various unfavorable events. And finally, the last group on this slide is patients with psychotic disorders or psychosis. And we see, once again, there's pretty unequivocal evidence, if you summarize all the studies and put them together, that the results come down on the harmful side, and they are significantly different from no difference between placebo or control group and the medication group. Now, those were clinical populations or specific populations. This slide summarizes outcomes in the general population. And these are lots of different outcomes put together. And we see that, once again, we have a lot of studies suggesting harmful effects. And this isn't just healthy people. And we have, again, studies showing harmful effects on the whole in a rather unequivocal way. So cannabis use has been studied a lot in terms of its relationship to psychotic disorder. There's quite a bit of debate as to whether cannabis use leads to psychosis. There's some concern about whether the the factors inside individuals that cause them to use cannabis are the same factors that lead them to have psychosis. But there was a study that was done across multiple countries in Europe, and that study found that compared to community controls, psychotic patients were more likely to have used cannabis on the whole, and much more likely than the controls to have used what was called in the study the high potency use. And in this study, again, the results were aggregated, and it was found that those who were daily users of high potency cannabis had greatly increased risk for incident psychotic disorder. This is across European countries and in Brazil as well. And here's a list of additional studies that have been published, all of them within the last, almost all of them within the last few years. And it's a variety of different outcomes. We've got cardiovascular events, the cannabinoid hyperemesis syndrome. That's a sort of violent vomiting syndrome that can bring people to emergency rooms. It's rare, but it's serious when it happens. Perioperative morbidity and mortality, psychotic and non-psychotic bipolar and unipolar disorders, psychosocial problems. And then the last one on this list is giving rise to the risk for cannabis use disorder or cannabis dependence. And that's a segue into the topic that I'm going to talk about next, which is cannabis use disorders. So here are the diagnostic criteria for cannabis use disorders according to DSM-4, which was used for a long time and is the basis for the findings in a lot of studies that are published in the literature, and DSM-5, which has been in effect since 2013, so it's 10 years already, but some studies have been a little slow to adopt DSM-5. So I think it's useful to look at the criteria for both of these disorders so we're clear what we're talking about. So this is the criteria for DSM-4. You'll see there's two conditions here, abuse and dependence. And here are the criteria for DSM-5. So there's just one disorder here because a lot of analyses that were conducted in the process of revising the DSM-5 criteria showed that when you put all these different symptoms and criteria together, they really didn't fall out into two distinct categories. They really kind of aggregated together, but in different severity levels. So the symptoms that were added for DSM-5 for cannabis use disorder included withdrawal, which hadn't been present in DSM-4 because at the time DSM-4 was published, which was 1994, there wasn't sufficient evidence for a withdrawal syndrome from cannabis. And then craving was also added in DSM-5, and that was added for cannabis and for all the other substances as well. Now, there's an ongoing belief that the risk for cannabis use disorder is very low among people that use cannabis, that it's just, people can use cannabis without much concern that they're going to develop a cannabis use disorder. But that also is based on very old research, studies that were done in the early 1990s when cannabis was still a much weaker substance than it is commonly available now. And this study that was a meta-analysis showed that people that used cannabis, any users of cannabis, had a 1 in 5 risk of developing a cannabis use disorder. That's about 20% of those who used it. And the risks increased if cannabis use was initiated early and or used frequently. So that is a contradiction to the idea that cannabis use disorder is rare amongst people that use cannabis. And there's another study that was published more recently. This was a prospective study that followed individuals over time. So they were assessed at a baseline interview, and then they were followed up for periods between 3 and 17 years later. So what you see on the left is the frequency of cannabis use in the baseline interview, ranging from never to 1 to 11 days in a year, all the way up to pretty much daily or near daily use. The right-hand column shows the increase in risk by the final time they were interviewed relative to how often they'd been using cannabis at the baseline or the beginning of the period. And you can see that the risk goes up pretty markedly for cannabis use disorder, depending on how often they were using cannabis at their initial or baseline interview. So it's not a rare condition, especially amongst people that are frequent or regular users. So let's take another look at the cannabis withdrawal criteria that are in DSM-5 and DSM-5-TR. The TR stands for text revision, and that was published last year by American Psychiatric Association. So at least 3 of the symptoms listed before in the bullets needed to develop within a week after cessation of heavy, prolonged use. And these symptoms are required to cause distress or impairment and not attributable to another medical condition or another mental disorder. So what are we talking about here when we're talking about the symptoms of cannabis withdrawal? We're talking about depressed mood, changes in appetite or weight loss, trouble sleeping, restlessness, anxiety, and irritability or anger. And I will suggest that there may be a perception that cannabis is effective for treating symptoms of psychological problems or these symptoms that are shown here, because if they are regular users of cannabis, they may have developed cannabis withdrawal, and then the symptoms decrease when they experience them if they use the cannabis. But what they're actually doing is perpetuating ongoing cannabis withdrawal by experiencing the symptoms, using cannabis to get rid of them. The symptoms go away, so they feel better, but they continue to experience the symptoms when the effects of cannabis wear off. And so it's an ongoing cycle. And that means, that clinicians working with patients that have these symptoms need to try to do a pretty good job of parsing out with patients what's going on and when these types of symptoms occur, and think with patients who may be a little resistant to the idea that the cannabis use could be contributing to the problems rather than fixing them. So what are some potential influences on the prevalence of cannabis use and cannabis use disorder among adults in the United States and elsewhere also? So I'm going to talk here for a few minutes about the changing cannabis landscape. So what do we mean by the landscape? Well, we're talking partly about changing attitudes and beliefs. We're talking about changing product potency. We're talking about changing state cannabis laws and legal availability. And with legalization, commercialization, marketing, and advertising. So first, it's really clear from studies that have been going on for quite a number of years that the average potency or strength of THC-9, which is the active element in cannabis, has been going up pretty steadily. These are illegal seized samples, but illegal samples may be irrelevant pretty soon, especially if cannabis ends up getting legalized at a federal level. We don't know if that will happen or not, but a lot of people have been suggesting it. And this is another way of looking at the change over time in the potency of illicit cannabis samples that have been analyzed by the same lab over a course of many years. So they've been using the same procedures to analyze the potency, and they show that the potency has been increasing. And of course, there's a lot of other cannabis products now as well. So it's not just smoking joints as it might have been in the 60s or 70s, but there's vaping, there's using concentrates, there's using actually buds or plant material with a vaporizer, and then using dab rigs, which really gives a very potent dose of cannabinoids to people that use these methods. So people are getting quite a stronger dose. There's some people that think, well, people titrate their dose. If they're using a stronger version or they're using a stronger product, they will just use less of it. And there's some evidence that that happens with some people, but then there's others that seek out these products because they are stronger, which suggests that they are interested in achieving the stronger effect. So in terms of changing attitudes towards cannabis have really changed pretty markedly over the years in the US. And, that's not so atypical when you think about other substances. I mean, the attitudes towards alcohol have certainly changed over time a lot, from prohibition to, much more recent situation. And attitudes towards opioids have changed a lot too, from thinking they will cause addiction in everybody to thinking they're really harmless substances that can be distributed by doctors without concern, yeah, there we go, to the realization that widespread distribution of these drugs is not a good idea and has led to a lot of harmful outcomes. So if you look back in the literature, there was an article that was published in the American Journal of Nursing where it was a statement that marijuana users will suddenly turn with murderous violence on whoever is near and run amok with knife, axe, or gun, which is so exaggerated compared to the way we think about it today. But, you know, my mother, I'm maybe older than a lot of people in the audience for this webinar, but we're going back some years. My mother believed that if you use marijuana, it was a short route from there to heroin addiction. So attitudes have changed quite a lot over time. And if you haven't watched Reefer Madness, it's a little bit of an entertaining and informative look at the way people thought about cannabis in years gone past. In more recent years, of course, attitudes have changed a lot. So this was a paper that was published now, I guess it's 7 years ago, that showed that over a period of 12 years, the perception that marijuana had no risks at all more than doubled. The perception that there was great use in cannabis amongst adults went down. And if we look at changes over time in the perceived risk of various substances, we see on the top of this figure, the black line is heroin, the kind of gold colored line is cocaine, blue is cigarettes, and purple is drinks of alcohol. And those, you know, there wasn't that much change. You don't see that much change over time in the perception of risk from using these substances. But over the period of time that we're looking at, the perception of risk in using cannabis did decrease considerably by about 1/3 from where it was at the beginning of this period. Consistent with that, the support for legalizing marijuana has gone up over the years. There have been polls taken periodically over quite a number of years at this point of the general population, and it was at a low in 1969, where only 12% of adults believed that marijuana should be legalized, reaching over 2/3 in 2021. And my guess is that if they did the poll again today, it would probably be even higher than that. And of course, a lot of states have legalized. I find that I end up needing to update this map practically every time I give a talk. The blue states are those that legalize for medical purposes only. The green states are those that legalize for recreational purposes. And all of those states started out with medical only and then transitioned to recreational use. So at this point, the number of states where marijuana hasn't been legalized at all, they're in the minority. And with every election, the number of these states does shrink gradually over time. So when states legalize, unless there are regulations in place that restrict what's done in terms of commercialization, the commercialization activities do start. So there's been a lot of interest in the cannabis industry, which you could call a burgeoning industry at this point, in the potential for profit and for growth. And most state cannabis laws are industry friendly rather than public health friendly. So we see a large estimate in terms of growth of retail sales. Canada has a different approach to legalization than the US does. In Canada, they legalized for recreational use in 2018, but across the country, they implemented an approach where there's some commercialization allowed, but there's a lot of public health messaging as well. And so they haven't seen some of the dramatic increases that I'm going to show you soon. But, the commercialization, when there's not a lot of public health regulation accompanying it, leads to, pretty exaggerated claims or advertising that really is designed to attract users, either new users or encourage users to use more. So this becomes an issue when people start using more and they have some of the adverse consequences. So where does that leave us in terms of time trends in cannabis use and cannabis use disorder among US adults? Well, these are long-term trends in adult use of cannabis. The blue line on top is adults that are aged 19 to 30. These are national survey results from a study called Monitoring the Future. The bottom line is the older individuals. And so we see here something that you would expect, which is, cannabis use is usually higher in young adults than in older adults. But we see in both groups that over time, since about 2008, that cannabis use has been it's pretty steadily increasing. This is for any use in the last 12 months. And this is for daily use, which is the much more risky pattern. And we see once again that since about 2008, there's been pretty steady increases over time in adults. What about cannabis use disorder? Well, this was a paper that was published now about 8 years ago that was based on a comparison of two surveys that had pretty similar interviews and questions that were conducted 10 years apart. So in 2001, 2002, we see that the estimate of cannabis use overall in the adults was a little bit less than 5%, and that had gone up to 10% by the end of the study period. And here we see the increase in cannabis use disorder overall, and we see that increased between these two surveys as well. We see a pretty similar result for DSM-5 cannabis use disorder using a different set of national surveys. This study was published now about 4 years ago. So we've been working some with Veterans Health Administration data, which is the Veterans Health Administration is the largest integrated healthcare system in the US. There are about 9 million patients enrolled who were veterans in the US Armed Forces. And the VA keeps an electronic health record database that includes medical and psychiatric diagnoses made by clinicians or providers. Treatments are recorded, prescriptions are recorded, mortality is recorded. And the VA data are used for a wide variety of research purposes. And in my research group, we've used VA data to study cannabis use prevalence trends and variables that are associated with that. So here's what we found when we first look at trends over time in cannabis use disorder. And we see that looking over the period of time from 2005 to 2019, in the oldest patients, the red line on the bottom here, they started out with near zero prevalence, and they had gone up over time. And the green line in the middle is the middle-aged patients, and the blue line on top is the older patients. So we see that the oldest patients had the steepest increases over time. The middle-aged and younger patients started out at about the same level, but the younger patients increased much more. What about the role of state medical and recreational cannabis legalization in cannabis trends in the VA and in other samples as well? So first you could ask, how could more permissive cannabis laws increase cannabis use and harms? Well, it can increase desirability by signaling that because cannabis use is legal, it's safe, advertising is permitted, can reduce disapproval and perceived harmfulness. Enacting cannabis laws can increase availability through a lot of distribution routes, dispensaries, retail outlets, online sources, home delivery, home cultivation, and by permitting an emerging for-profit cannabis industry whose aims are to increase the numbers of users and to increase the amount that the consumers use. So there's been one study in the general population of the relationship between recreational cannabis laws, marijuana use, and DSM-4 cannabis use disorder using surveys, repeated yearly surveys conducted between 2008 and 2016. And the results of this study were that the cannabis legalization for recreational use didn't really affect the youngest population at all, and that's the adolescents 12 to 17, and had also had practically no effect in the young adults 18 to 25. However, in the you might call them older adults, those age 26 and older, there were significant relationships between the enactment of these laws and whether the participants in the surveys were likely to use marijuana at all, whether they were likely to be frequent users, and whether they had a cannabis use disorder. And these results show that there was an association, a significant association between living in a state that enacted the cannabis legalization and having all of these outcomes. So we also took a look at this using the Veterans Administration patients. They're an important at-risk population for cannabis use disorder because they have high rates of psychiatric disorders and they have high rates of chronic pain. And those are both risk factors for cannabis use disorders just in general. So we addressed the research question about whether state medical and recreational cannabis laws played a role in the increasing cannabis use disorder prevalence that we just saw in the VA patients. This is methodological information. I'm going to skip over some of these details, but we can come back to it at the end if you like. And this is what we found when we compared the prevalence over time by where the states had gotten to by 2019. So this doesn't show as they changed, but in 2019, there were some states that had not legalized at all. That's the black bar. Some states that had legalized only for medical use, that's the blue bar, and some states that had legalized for recreational use also, and that's the green bar. And we were kind of surprised that there wasn't a bigger difference here. We see that the states that had not legalized at all had lower rates of cannabis use disorder in the VA patients over time for many of the years, although not all of them, but the lines were closer than what we expected. When we broke this down, so we did further analyses that I'm not going to go into necessarily in this talk, but we looked at the amount of the increase overall in cannabis use disorder prevalence that could be attributed to change in the law. And here you can see that for medical cannabis enactment, only about 5% of the increase could be attributed to the change in the law, suggesting that there were a lot of other factors that were going on that accounted for the increases. We found not quite 10% of the increase could be attributed in the overall sample to recreational laws. But once again, that left a lot of room for other explanations besides just the laws. Simply enacting these laws wasn't accounting entirely for these increases by any means. When we broke this down by age groups, we didn't find a relationship between enactment of the laws and increases in cannabis use disorder prevalence in the youngest group. This is what we found in the middle-aged patients, which was really pretty small effects of the laws. And what we found was we got the biggest effects for the legalization in the older patients, particularly the legalization for recreational use. And here, that legalization accounted for not quite 20% of the increases in this group. And it can be that older people are really sensitive to whether something is legal or not. You know, they're not as risk-taking as their younger counterparts, and they don't want to get engaged in illegal behavior. So if they're going to use a substance, they're going to wait till it's legal. What about some trends in cannabis use disorder prevalence in the VA patients by clinical comorbidity? Well, here we looked at differences between patients who had a pain diagnosis. There were 11 clusters of pain conditions that formed a typology of chronic pain diagnoses, and we compared patients that had none of those to patients that had one or more of them. And the bottom line is the patients without pain, and the green line on top is the patients that did have a pain diagnosis. And you can see that the patients with pain started out at a higher level than those without pain, but their increases were much sharper over time. They increased more than the patients that didn't have any pain diagnosis at all. And when we broke this out by patients that had no pain categories, that's the blue line again on the bottom, one pain category, that's the middle line, the green line, and two or more pain categories, which is usually interpreted as being a more severe pain indicator, that the results were especially pronounced in those that had more severe pain. These patients had the sharpest increases over time in the prevalence of cannabis use disorder. So they had a greater increase in risk for cannabis use disorder than the other patients. When we examined that by whether the patients lived in states that had legalized cannabis for medical or recreational purposes, we found that there was a big difference between patients with pain conditions and patients without pain. So here on the bottom, the dotted lines are the patients without pain. And you can see that in 2005, they all started out at a pretty low level of cannabis use disorder, and they were all pretty much the same. And there was some splitting apart of the different groups over time, but not a very pronounced widening of the differences by 2019. In contrast, if you look on top, the solid lines, these are the patients that did have pain conditions. So you can see that at the beginning of this study period, the first, let's say, 4 years, there really were not much, there were not much difference between patients with pain in the states with these that had enacted these laws. But over time, while there were increases overall in patients with pain, the increases were much more pronounced in the patients that lived in states that enacted either medical or recreational cannabis laws. There wasn't a big difference between what type of law was enacted, but if any legalization occurred, that considerably increased the risk for cannabis use disorder in the patients with pain. What about looking at patients with psychiatric disorders? So once again, we compared patients without the disorders to patients with disorders. The green line on the top shows that the patient had any disorder from at least one of 5 categories: depressive disorders, anxiety disorders, PTSD, post-traumatic stress disorder, bipolar disorders, and psychotic spectrum disorders. And here you can see that there really wasn't much increase overall in cannabis use disorder prevalence in the patients without the mental health conditions over time. But there was a pretty pronounced increase over time in the patients that did have one or more of these psychiatric conditions. And this is what happened when we broke out the categories separately. So we see that the patients with the more common conditions, depressive disorders, anxiety disorders, and PTSD, kind of bunched together. So they had an increase. It was pretty noticeable, and they were pretty similar. They weren't very different from each other. And the patients with the more severe mental illnesses, the bipolar disorders and psychotic disorders, the subgroups of patients with these disorders were smaller, but their prevalence of cannabis use disorder was higher, and they increased more over time than the other patients. And in this slide, in this figure, we allowed comorbidity between the different conditions. There's a lot of, as you probably all know, there's a lot of comorbidity between these different conditions in various patients. Here, we didn't allow comorbidity. So we excluded cases that had comorbidity, and we just included cases that had the single diagnoses. And we see, once again, that those with depressive disorders, anxiety disorders, or PTSD had increases, but the increases were sharper in those with bipolar disorder and with psychotic disorder. So where does that leave us? Well, in terms of strengths and limitations of the findings from the VA research, strengths were that there were large sample sizes. We were able to analyze between 3 and 4.5 million patients a year, which is really a substantial bonus in terms of being able to study the relationship between these different conditions over time. The data stretch out over many years of data, and we found also in findings that put building in time lags for enactment of the laws and legally permitted dispensaries didn't really change our findings hardly at all. Limitations of these data are that cannabis use diagnoses were made by providers, and they tend to diagnose what comes to their attention. So they may have missed milder cases that just, didn't make it to their radar. So what you have here is probably results for patients that had more severe conditions. In addition to that, Veterans Health Administration patients are not nationally representative. More of them are male than in the general population. And they do have a lot of medical and psychiatric conditions, many of which are acquired during their time that they're of service in the service. But the size of the data and the richness of the data do give an opportunity to do a lot of work to study time trends and influences on those trends. So in terms of future research directions, what we're doing right now is we're looking at the relationship between psychiatric comorbidity and the effects of medical and recreational cannabis law enactment on cannabis use disorder prevalence. We're also examining the relationship between these laws and their effects on opioids and other outcomes. People have suggested that when you enact cannabis law legalization, that people will use the cannabis instead of opioids, and that will be a benefit of doing that. And we're in the middle of we're analyzing those outcomes now in the VA patients. The VA also, because of all the information that's collected on medication, we are hoping to be able to examine change over time in the risk for cannabis use disorder by whether patients were prescribed opioids or psychotropic medications. So implications of the study, I believe probably people in this audience could talk about that some too, but to my mind, the need is increasing for screening and treatment of cannabis use disorder just in generally, but especially in patients with chronic pain and with psychiatric disorders. This need may be greater in states that have enacted these laws, although that need may be diminishing over time. And again, if cannabis ends up being legalized federally, then the state laws are going to be a moot point. And I think the implications of the study also are that discussions with patients about their cannabis use, they do need to take into account widespread beliefs in cannabis safety and efficacy, which may be fostered by a growing for-profit cannabis industry using techniques that have been used by the tobacco and opioid industries, but being sensitive to where patients are coming from, starting where the patient is at, so to speak, and talking about their cannabis use and whether some tryouts of change in their use may help improve their status in terms of other conditions. So I'm going to just end by acknowledging gratefully my support for this research from the National Institute of Drug Abuse, a really terrific group of collaborators from Columbia University and NYU, and the Veterans Administration. We couldn't have done this study without this active and really engaged collaboration between the two teams. I've had funding for an unrelated research project on the measurement of opioid misuse, abuse, and addiction from Syneos Health. And there's my contact information. And if any of you have questions after this webinar and you want to email me, actually the Gmail address is a little bit better if you want a response, but I welcome your questions and I'll be interested to see what you may have to say. So with that, I'll end. And I guess we still have a little bit of time for questions. So there we go.
Thank you so much, Dr. Hasin. We've gotten at least one question so far, and probably more will be coming in. But the first one is, how is cannabis use typically operationalized across studies?
That's a great question. So there's sort of two aspects to it. One of them is the frequency of use, and the other is the quantity. And frequency of use is, it's measured in different ways. And that's the easier way to measure cannabis use. So you can ask people, did they use it all in the last 12 months? Or how often did they use? Did they use, every week? What was the frequency of using? And there are different measures also called, like one is the timeline follow back, where people are asked how many days did they use cannabis in the last 30 days. The more tricky part is to analyze the quantity, because unlike alcohol, where you have a standard drink size, which not everybody knows, but you can educate your study participants what is a standard drink and what is meant by that, or pills or cigarettes, which still come conveniently packaged in a pack of 20. So you can ask people about how many packs a day did they smoke. Cannabis is all over the place. Every state is different. The industry it's so variable. So it's really kind of the Wild West in terms of trying to measure the quantity and also the potency of the products that people are using. And there's studies that are underway now to try to standardize that. And it's important to be able to do that because there's interest in being able to quantify the level of use that leads to the risk for the adverse consequences. And if you can't really measure people's use accurately, it's going to be hard to think about a threshold for the level of use that leads to harm. Like for alcohol, there's 5 or more drinks on a given occasion for men and 4 or more drinks for women. It's actually based on a fair amount of research. We need to get a measure like that for cannabis, and we'll get there, especially if cannabis is legalized nationally, so national standards can start to be put in place. But right now, you just have to do the best you can. How many joints, how many puffs, what kinds of products, do you know the potency of your product? What was it? And that's how it's measured.
Interesting. Thank you. Another question, and this might be a big one, but how are the harms and benefits different for THC use versus CBD use?
So CBD is really quite different, and I haven't really considered that at all. So it's cannabis. I mean, marijuana, plant marijuana. It's really a very complex. It has lots. It has like something like, I think, 90 something different elements in it. So we're not talking about just THC. We're not talking about just CBD. I've been talking about THC. CBD products are a little bit different. They may be sedating. They may be, different for, treating different medical conditions. But what I've talked about today has been THC.
Okay. Next question. Have any of your studies or studies that you're aware of examined cannabis use and its impact on reduction or increase of psychotic symptoms?
So I showed, when you get the PowerPoint slides, you'll see that in patients who have psychotic disorders already, there's pretty clear evidence that using cannabis makes the symptoms worse. And it's not 100% clear if that's because the cannabis itself makes the symptoms worse, or the cannabis use makes people a little bit less adherent to their medication routines. I'm just thinking if there's a slide in the presentation that shows that. I may not have included, I don't think I included that, but if anybody's interested, email me and I will send you a slide from a different talk that shows you a bunch of studies that have looked at that.
Oh, great. Wow. That's a very generous offer. Thank you. I'm not seeing any other questions. Does anyone have any additional questions? Give it a second and I'll just fill some space here by letting folks know. Please be sure to fill out our survey, which is above. And also, I will include information in the email today about our next webinar, which will be on the 15th. And a question just came in. That's so exciting. Has there been research on the difference between different kinds of THC, such as Delta 8 and others?
So Delta 8 looks like it's a little bit less potent than Delta 9. And it's, there are some studies. The findings are kind of limited at this point, but actually I have someone, he was a research fellow up until recently, and then he got his own grant, so he's not a research fellow anymore. So he has a paper that came out on Delta 8 use, Ophir Livni. And again, if you email me, I will refer you to the paper. Be happy to do that.
Let's see. How do we work with our clients or patients with chronic pain who use cannabis and don't want to take opioids or nerve blockers, etc., in light of knowing about cannabis's potential harms? Do you have any suggestions?
That is a great question. So there are a lot of first of all, there are treatments for pain. I mean, the whole pain issue is really quite a dilemma at this point because there's no single good answer to it. Opioids were not the single good answer, and cannabis is not really either. But there are a lot of non-pharmacological treatments for pain that are effective. They're behavioral treatments, they're CBT. There's a whole range of them. And I think, so I showed you results from Zach Manis in this PowerPoint. There's a paper on trends over time and differences between the patients with pain and without pain. It was the slides that showed the patients with one pain condition and two pain conditions. So he, in the paper that he published on this, there's a whole discussion section that includes other types of treatments that are available for patients. They have to have some patients need to be patient, right? They need to have some patience with the behavioral treatments, but there are other other interventions that are available, that when studies have been done of them, they're shown to be effective. So it's something to find out about and to look into and to consider offering to patients who don't want to use opioids, which is completely understandable at this point, and may have concerns about cannabis either because of risk of adverse outcomes or they just don't like some of the effects. There are other options available, and I believe if you look at Zach Manis's paper, you'll find a discussion of those.
Wonderful, thank you. Another person says there seems to be a prominent dip around 2016 regarding use across different analysis. Is there a specific reason for that?
Yeah, there is. It's a methodological reason, not a real world reason. So in the VA uses ICD-10 CM diagnoses, and a lot of healthcare systems use those diagnoses. So ICD-9 CM had been in place for many, many years, but in 2015, October of 2015, there was a transition to ICD-10 CM. And in the VA, all the patients, were not automatically carried forward from their ICD-9 diagnoses to ICD-10. So providers had to enter a new condition once the system had switched to ICD-10 CM. And it took the providers a while to get around to entering the conditions, because it was like a clean slate once that transition had taken place. And it looks like that's the explanation of that dip. If that is that clear?
I think so. If that's not clear, maybe the person who asked the question can let us know. And then one more just came in, someone asking if you could clarify which paper by Zach Manis you are referring to.
Okay, so let me see. Give me 1 second.
Sure. Thank you for doing this.
So it's, can I share the screen again?
Yeah, please. I mean, you are sharing it actually already. We can see that.
Okay.
Yeah.
Okay, so the author is Zach Manis et al. And it's in the journal Pain, and it was just published this year. So you should be able to find it. Great. With that.
Great.
If people can't find it, they can check with me, and I'll ask one of the research assistants to send the copy of the article.
Great, thank you. One more question. Would ICD-10 diagnosis for cannabis switch to a behavioral health diagnosis?
Say the question again.
It says, I'm not sure I understand this either. Would ICD-10 diagnosis for cannabis switch to a behavioral health diagnosis? For cannabis.
We're talking about cannabis use disorder.
Yeah, I think so.
So that's different from a behavioral health outcome.
Okay. Was that your question, Eric? I don't know if you want to clarify that in the chat. Could we see the last slide, the implication slide again? And Eric says, yes, that was his question, by the way. The implication slide. There we go.
Can you see it?
Great. All right. I'm not seeing any more questions. So I'll just let folks know our next webinar is on November 15th, and it is titled New Paths for Advancing Adolescent Substance Use Research, presented by Dr. Karnick. It'll be offered in collaboration with our partners at the NIDA CTN, and we'll have 1.5 CE and CME available for that webinar. So be sure to register for that. I'll include the link in the email I'll send out later today. Thank you, everyone, for coming, and thank you so much, Dr. Hasin, for joining us today. Really helpful talk.
My pleasure. Thank you for asking me.
All right. Have a great day, everybody. Bye-bye.
Bye-bye.